do delivery. That's the second stage of labor and the last stage of labor. Second stage of labor entails the delivery of the baby from the fetus from the baby, and the last stage entails the delivery of the placenta. So before that, I started the anatomic examination to know the side the baby that is lying on, and to look for the engagement. Engagement simply means if the fetal head is in the pelvic. The pelvic. Yeah. Yeah. And so, also it doesn't have to be the head. Yeah, any representing part. Maybe the head or bridge, that's the foot. Yeah, so I studied the hand hygiene. So delivery is usually a sterile procedure. When we say sterile, we think it's a procedure that involves a lot of maybe infections and all that. So you have to have sterile blood zones, practice hand hygiene, all those things. Okay, so what we mean when we say sterile procedure. You have clean procedures. You can just maybe sanitize your hand and maybe touch the abdomen where you're not coming into contact with fluid. But for sterile procedure, anywhere you're going to handle with blood. In this case, we have amniotic fluid and all those. You can get infections from that. Also, you can transmit infections to the mother. So you need to have protective gear. So hiyo toni inafaa kwa ndani ya maji. This is kuna nyasi sterile na kuna sterile. So kama si sterile, haingekuwa hapo juu itakuwa chini. You get it? Then a must create rapport with the patient. So I'm Natalie. Okay, I'm Francis Kamau, the nurse on duty today. I'm going to regulate the process of delivery. Maybe I need your consent. As maybe you can know your name, please. She's my Natalie. Here's my assistant. She can introduce herself.
Okay, good morning. My name is Aida. I'll be the assistant to help the nurse on duty today. We're going to help in the process of delivery. Hope you got it. And the process is going to be a bit uncomfortable, but after that you're going to be okay. Thank you.
Okay, I'm going to start with the examination of your abdomen. We are going to start with the inspection. First of all, we inspect if there's any scar on the abdomen. Then we inspect for the linear hydra. That's the dark line from the umbilicus, the pubic one. Then we look for the stripe gravidera. These are just the stretch marks during pregnancy. After that, we are going to do palpation, the abdomen. We are going to apply the Leopold's maneuver, mass for grips. We have the first one. First of all, we are supposed to test the mother's legs, starting for the first 3 grips. That is the bundle grip, the lateral grip, and the pollix grip. Then the last grip, the pelvic grip, we are supposed to test the mother's face. So we are going to start with the fundal grip. We want to check where the fundus is. The fundus is the upper part of the uterus. So when you feel the fundus is here, you can decide to measure the tape measure. For instance, here we don't have a tape measure, so you come and divide. This is the umbilicus. So on this part you divide it by 2. On this part you divide by 3. Yeah, here. So when the fundus is here, that means the gestational age is 16 weeks of pregnancy. When it's at the umbilicus, it's 22 weeks of pregnancy. When it is on the first mark, it's 28 weeks of pregnancy. On the second mark is 33 weeks of pregnancy, gestational age, and here is the 37 week of pregnancy. So After the frontal grip, we go to lateral grip. We want to check where the side where the baby's back is. So we'll support this, apply pressure on this side, then palpate this side, then apply pressure on this side, you palpate this side, you will feel the baby's back. Then after that we go to Foley strips. You want to lock the presenting part. That is the part that will come out first during delivery. Doing like this, you will feel. If it's the head, you will feel. Then we'll confirm with the vaginal examination. Then if it's the foot, that is breech presentation, we'll also feel. Then you come to this side, you do the pelvic grip. You want to look for the descent and engagement of the baby. Okay, we are done with the abdominal examination. Now we are going to do the vaginal examination first. That we are going to feel if there is contractions by palpating the abdomen. Continue. By palpating the abdomen, to feel that there is contractions. Then I'm going to instruct my assistant to check for the fetal heart rate. To check for the fetal heart rate, after you have felt that the head is the present part, you look for the back of the baby. So on this scenario, let's assume the back is on this side. So you check the head and the umbilicus. Then there is a midline here. So we are going to search for the fetal heart rate at this point. So my assistant will
So I'm going to check for the fetal heart rate. Ideally, and it is supposed to be within the range of 110 to 160 beats per minute. That is the normal rate. So if it's below 10 or above, there will be a problem. So I'm going to use my stopwatch, set in 1 minute, and listen to the fetal heart rate. So after you listen, you have to confirm two things. That is the intensity and the frequency of the fetal heart rate. So now, in our case, it is 145 beats per minute. That is within the normal rate, and it is regular. So this tells us that the baby is okay, and he or she is not in fetal distress.
if the baby is having volume 35 here, that is high heart rate, high rate of the heartbeats. Maybe he or she can be distressed. It indicates that the baby is in distress. So after that, I'm going to do the vaginal examination. Now from that part, it's a sterile procedure. So I need to have my gown and sterile gloves. So before gowning and putting on the gloves, I have to do hand scrubbing. the difference between hand scratching and washing is that the normal hand washing you wash up to the wrist point. So the other one wash up to the elbow point, and this is 3 times. I just done one time because of time. And the last wash was also wash up to the wrist point. So I'll instruct my assistant to open the first part of the delivery plan. The plan was starting from the this time. Then I will advise my assistant to give me the gloves, sterile gloves. This is a sterile field. Here, the assistant is not supposed to touch it. So before that, I will let it down so that I can put my gloves. The front part is sterile. They are this is I instruct my assistant to put me some antiseptic solution in the belly. Remember your mouth will remain like this. So I want to clean the vulva before I do the vaginal examination. So we're going to take 5 folds. Stop them in the antiseptic solution. Then I just close. Using the dominant hand. Then using the dominant hand, I drop the non-dominant hand. Then you are cleaning starting from the farthest labia majora. That's what I want to do. Labia majora is the outer one. So it's once downward. Then I discard. the nearest labia majora, take the other one, to the nearest farthest labia minora, the inner one, then the fourth one, to the nearest labia minora, then the fifth one, use the dominant hand, you clean the vestibule. The vestibule is the center part once. Okay. So after that, I'll instruct my assistant to put me some KY gel. So I'm going to look for the dilation of the cervix, whether it's 10 centimeter, because my mother is supposed to start pushing, and it is 10 centimeter dilated. So for our case, the baby is late drowning, so I can't go far. Then you look whether the vaginal opening can accommodate the blood of the baby through the vagina. Then you just feel it. Then after that, you look the status of the liquid. That is the fluid, whether it has blood or it's green in color. If it's green in color, we call that meconium. So that means the baby's poop, the baby has pooped inside, and it's bad because the baby can aspirate it and cause some complications. So the cervix is 10 centimeter dilated. So we are done with the VE, vaginal examination. So I'm going to discard these gloves and put on another sterile gloves for the laboring now. This is the last my resistance. So I'm going to instruct my mother. So Mama Natalie, you push when there is contractions. When there's no contraction, you relax and take a breath. You are not supposed to push when there's no contraction to prevent tear. This part can have a tear, and the mother can be exhausted when she push all the time. So when there's contraction, she push. When there's no contraction, she relax. So Mama Natalie, you're going to push when there's contraction, and I'll also instruct my assistant. If there's no contraction, she listens to the fetal heart rate. We listen to the fetal heart rate when there's no contraction because the contractions are so strong and intense, so they interfere with the fetal heart rate, with the listening of the fetal heart rate. That's why we take the fetal heart rate and there's no contractions. So, Mama Natalie, farthest leg, you rotate anti-clockwise, you come to the abdomen, come to the nearest leg, then you instruct the patient to lift the buttocks so Manhattan, you're going to push in these contractions. If you feel contraction, you push. Then we are going to don't have close, so we are going to assume this is the close. You support the perineum. The perineum is this part, the part between the vaginal opening and the anal and the anus. So you in the pinch to avoid tearing of the perineum. Push, push. Then as she push, you have to encourage her. Yes. Now we are almost. You push when you have contractions. Almost. Yes, continue. We are almost. And see the head. Push, push. Yes, we are almost. Continue pushing. And see the crown. This is what we call crown. On this stage, this is what we call crown. On this stage, the mother will have a very strong burning sensation because the head is stretching the tissues. And this is what we call a ring of fire. Ring of fire because of that burning sensation. So continue pushing. Now we don't have contractions, so the assistant will send the fetal matrix. The contraction number to continue. Remember to support the perineum to avoid tear. And now, if the vaginal opening is not can't accommodate the head, you can have what we call an episiotomy. You take this and cut. You can have mediolateral episiotomy or midline episiotomy and cut. To increase the opening. So let's continue. Yeah, and make it. Continue. When the head is out, yeah. When the head is out, yes, you wipe it. You wipe the mouth. You start with the mouth. You want to wipe the face, but you start with the mouth to prevent aspiration of any liquid that is in the mouth. You wipe the mouth, then the nose and the eyes. So after there, we have restitution, that is external rotation of the head, so that we can deliver the shoulders. Remember, I started with engagement. This is the mechanism of labor of the baby comes out. We start with engagement, then descent, the baby will descend. After that, we have relation. After descending, when the baby enters in the pelvic floor, there will be resistance. So the baby's head will flex like this. After flexing, then we have internal rotation. Alla face also angalia chini. Hiyo ndio tunafuata ID. Sasa angalia chini, so we will do. So after internal rotation, we'll have extension of the head. No, it will be normal. After that, we have delivery of the head. Then we have delivery of the head now. Then we are going to support the parietal bones. These ones here. We are going to support the parietal bone as the baby restitute. Rotate externally. Remember, the baby is doing this on its own. We are not the one doing it. So the baby will rotate. So you have the delivery of the anterior shoulder. You press downwards. Then posterior shoulder. And now the baby will be out. The the code. Now I have to click on there and go on the baby. I give my assistant the grip and dry the baby. Okay, after that we are going to take what we call upper score on the first minute. Upper score simply means that's an abbreviation. After A is for appearance, P is for pulse, G premise, A activity and 4, and 5 respiration to check the status of the baby. Okay, after that we are going to clamp and cut the cord. We clamp it. We clamp it 3 centimeters from the umbilicus of the baby and 5 centimeters. Then cut the cord at the center. So make sure the cord that remains from the umbilicus should be 2 to 3 centimeters from the umbilicus of the baby. You put cotton. This the cord method. Now this we have something to cut that is direct. You just put it like this, the clamp itself and cut. So this will put cotton here to prevent that blood from splashing. Then after that, in the relation of service, show the mother the gender of the baby. Don't tell her, you show her.
And later identify the gender by herself. And then after that, I will
You take the baby to the resuscitate. This is what we call resuscitate. You warm the baby and instruct the assistant to take the upper score after the 5 minutes, after 5 minutes and after 10 minutes. The second and the third upper score, then measure the weight, the length, and the head circumference and the chest circumference of the baby while on the resuscitate. Now, after the delivery of the first baby, I'll palpate the abdomen to confirm whether there is another baby. Maybe they were twins. After checking that there's no any other baby, I call my assistant. Just we are going to administer a drug called oxytocin. This is to promote contraction of the uterus so that we can expect the placenta. We can deliver the placenta. So she's going to inject intramuscular on the thigh 10 international unit of the oxytocin.
So you're supposed to inject it on the outer part of the thigh, 10. It should be 90 degrees. And then you aspirate first to see if there's any blood and see if you are in the right place, then push. After that, use a dry cotton wool just to apply pressure.
And it works within 2 minutes. Oxytocin. Now after that, I'm going to use what we call controlled contraction. So control meaning I will wait until there is contraction. That's when I can pull the placenta. Contraction meaning I am applying pressure with the other hand to avoid what we call uterus inversion. The uterus, uterus inakuanga hivi, inaweza kuwa inverted viscomabular support. So I'll apply pressure here and pause. Okay, I'll instruct my assistant in a downward movement. Make sure you support it as it comes. And ensure you pull it when there is contraction and you have your kidney dish here to receive the placenta. When it reaches a point that you can see the placenta, now you have to rotate it in an clockwise manner to collect all the membranes that are in the uterus. In an clockwise way to collect all the membranes and receive it on the kidney dish. You will examine the placenta. So after that, you continue palpating the abdomen to it will help to expel the remaining membranes by through contractions. So after that, we are going to to wipe inside so that we can remove the remaining membranes. We are going to use the gauze, not cotton. We don't have gauze. So we have like five balls. Remember, these gauze we are not going to discard them. We are going to put them in the English so that we can look for the blood loss. So you are going to roll the gauze on your two fingers. Then put your fingers inside and wipe. Put it there. Roll the second one. You wipe. Remove any cloth or any membrane that is there. Just another one. You wipe. And the last one. You wipe. Then after that, you are going to look for process for any tear. You can look for the cervical tear. You'll be having light. Look for the cervical tear. Then perineal tear. If you did an episiotomy, we're going to suture that manner. After that, then we're going to clean the mother. Then you can look for the blood loss by just squeezing the blood on a calibrated cylinder maybe. You look for the blood loss in milliliters. So after that, you undrape the mother. So after that, you talk to the mother. You thank the mother. Thank you, Mama Natalie, for allowing me to be honest today. And we are going to assess you after every 15 minutes for the first 2 hours. Then after 30 minutes, to assess if there's any complication like there's something called postpartum hemorrhage. That is bleeding, excessive bleeding after delivery. So after that, we are going to examine the placenta now. On the placenta, we are going to look for 4 things. This placenta is not full. We are supposed to have membranes here. There's no membranes. We are going to look for 4 things. The cord, the fetal part, this is the fetal part, this is the maternal part, and there is something we call fenestrum. When there is membranes, there is an opening, and we call it fenestrum. So we start with the cord. With the cord, you wipe the upper part. Then, on the cord, we have blood vessels that supplies blood and remove waste from the fetus. So we will see two narrow openings. Those are umbilical arteries. They carry the vaccinated blood from the fetus to the mother, that's maternal. And we'll have a one wide opening, that is the umbilical vein that carries vaccinated blood from the mother to the baby. So after that, there is a jelly that protects the three vessels. We call it Wadon's jelly. So come downward, you look for two things. There's something called false note and true note. So false note, you might find that there is a big bump on the cord, along the cord, but it's not interfering with the blood flow. So that's what we call false note. Then on true note, you might find that there is just a knot on the cord like that, and it's interfering with the blood flow. So this is what we call a true note. After that, you look whether the cord is centrally inserted on the placenta. It should be centrally inserted. If it's inserted on the margins, that's abnormal. We call it bad tone insertion. If it's inserted on the membranes, real membranes. If it's inserted on membranes, it's abnormal too, and we call it the lamentous insertion. So after that, we look on the fetal side. This side is almost always shiny and it's grayish in color. We look for the distribution of these blood vessels. They should be evenly distributed. So after that, you come and assess the maternal side or the mother's side. This side is divided into cotyledons. We call them cotyledons. Like the way wanampira kwenye kuna community in Spanish. That's how we call it. They are supposed to be 18 to 24 cotyledons in a normal placenta. If there is one less, you should go for a data for the removal because it can cause bleeding. That's BPH. So after that, it's always reddish, red or pinkish in color. Then you can look for white patches on the maternal side. We call it calcification, white patches, or blood tissues. We call it infarction. This indicates that the mother maybe was using some drugs or an hypertensive mother. So after that, you look for the fenestrum. Fenestrum, that is opening, should be one. Then after that, there are these membranes. There are two membranes. One proximal to the fetus, that is nearer to the fetus. We call it amnion. It's thin, but it's hard to tear. Thin but hard to tear. The other one is we call it chorion. It's big but easy to tear. So we are done with the examination of the placenta. Remember, I sent my assistant to the resuscitator. So we are going to take vitals of the baby and the APGAR score. What's the APGAR score? 15 minutes? 5 minutes?
The APGAR score within the last 5 minutes were okay. So I first started with the appearance. There were no bluish extremities, so the baby is pinkish in color. That's a two. When you go to P, the pulse also was between the ranges that is supposed to be between 100 to 180. And I also gave it a 2, a score of 2. Now we come to the Greenmans. Greenmans, they were good. Greenmans, the reflex. Yeah, they were good. Also, I gave it a score of 2. And after that, we come to activity, the movement. The baby was moving well. I also gave it a 2. And now the lastly was the respiratory rate. I also checked it. It is between the normal ranges of 30 to 60. So I gave it a 2. The same as between the after score in the 10 minutes.
Okay, what we assess on after score? On appearance, if the baby's skin is blue from the top to the extremities, we give it 0. We range it from 1, 0 to 2. So that is 0. If the skin is pink but the extremities are blue, we give it 1. So, but if the baby is pink in color, the skin, give it 2. So on the parts, if there is no parts, 0. If the parts, there is parts but below 100, this time means 1. If it's above 100, give it 2. The grimace, if the baby can't respond to any stim like pinching or heat or anything else, that's how we rate it. So on vitals, we check for the respiration. The normal range will be that to 60 beats per minute. Breaths, not beats. Breaths per minute. Beats is per stage. Breaths per minute, 30 to 60. We look for the heart rate, should be 100 to 190 beats per minute for a newborn. After a month, it should be 90 to 180. When in the one 60 to 100. So after that, we look for the temperature. It should be 36.4 to 37.4 degrees Celsius, or in Fahrenheit, that's 97.5 to 99.3. Then after that, we look for the weight. What is the weight?
2850 grams.
2850 grams, yeah, it's measured in grams. Then we look for the length. What's the length? The normal range, the normal range should be 48 centimeters to 55 centimeters. Then after that, look, we measure. We are using the tape measure. We measure the head circumference. We don't have the tape measure here. We measure the head circumference. That is the area here. It should be 33 to 38 centimeters. After that, we measure the chest circumference. Use the nipples as your guideline. So it should be 1 to 2 centimeters shorter than the head circumference. It's very overall picture. So then after that, we measure the placenta, or it's a sixth of the baby's weight. Yeah. So after that, we have given thanks to the mother. Now I'm going to unblock. Ask my assistants. Yeah, we are done.